So what I'd like to do now is introduce our keynote speaker, Ruth Levine, who is the director of the Global Development of Population Program at the William and Flora Hewitt Foundation, where she leads a team that makes grants in reproductive health, education, and citizen empowerment around the world, and particularly in Africa. Dr. Levine started with a BS in biochemistry from Cornell University, then she earned her PhD in economic demography from Johns Hopkins University, and early in her career she worked on health and education projects in more than a dozen countries for the World Bank and the Inter-American Development Bank. She then spent nearly a decade at the Center for Global Development, a Washington, D.C. think tank, leading the center's global health policy program. From there, she worked on the Obama administration, at the U.S. Agency for International Development, and she joined the Hewlett Foundation almost 3 years ago. And with her vast experience in global health, she's authored scores of books and professional publications, including a pair of very influential reports on women's health, which caught our attention and really is the reason that we wanted to have her as our keynote. It inspired today's presentation, and those two reports were Girls Count, a global investment and action agenda, and Start with a Girl, a new agenda for global health. And with that, I'm very pleased to have Ruth Levine.
Thank you so much. I don't think we need the PowerPoint slide. It's just going to remind me of facial rejuvenation and the need for it. So maybe that could go away, whoever's responsible for this. So thank you so much. Great. For the opportunity to start off what promises to be an absolutely fantastic conference today. So something brought all of you here, and I don't mean just to this venue and this beautiful space, but I mean to a place in your lives where you really recognize and think about the importance of the health of girls and women. And I'm guessing for most of you, that has something to do with an awareness that women's health is really at the kind of crossroads of fundamental and fierce social forces. And that working on women's health issues really is about human rights and justice as much as it is about medical science. And I'm guessing too that it has something to do with your understanding that when girls are healthy and happy, they're more likely to become women who are healthy and happy. And then the next generation of both girls and boys has a better chance of thriving and prospering. So while you're maybe taking a moment to reflect on your own source of inspiration for being interested in the health of women and girls, maybe I'll just offer my own source of motivation. About 25 years ago, I was working on a study for the World Bank and the government of India. And the point of the study was to understand how India was going to finance its growing healthcare sector. And so I was a relatively young analyst at the time, and I was assigned to help project the number of hospital beds that India would require. And to do that, I was sent around to maybe a dozen or so hospitals around India in different medium-sized cities to interview the hospital directors, to wade through enormous piles of paper and information, and to come up with a report. And each of these hospitals, as I said, there may be a dozen that I had the chance to visit. Each of them was maybe the size of the Stanford Hospital, although, as you can imagine, not quite as well appointed. And at every hospital, I heard the same story. The director would shake his head, and he would say that his biggest problem was that he didn't have enough beds in the burn unit. And indeed, the burn units were full to overflowing. There were patients in every bed. In some beds, there were 2 patients. And almost all were young women. Some, of course, were victims of accidents. But most were victims of domestic abuse. They were burned for failing to bring enough dowry to their new husbands and in-laws, or for some other imagined transgression early in their marriages. And those marriages had occurred when they were very young. So they were barely out of childhood, and they were damaged likely for the rest of their lives. So there I was, assigned by the World Bank to count beds and to think about how to pay for them. And all around in the sights and the sounds and the smells was a problem of human rights and the gender-based violence that is so endemic in many, many parts of the world, along with institutional neglect and acquiescence on the part of the government and indeed the World Bank. It was plainly impossible to separate the technical challenge of financing more beds for more burn patients from the long and complicated struggle for equal rights. It's an image I have come back to again and again. I've done additional work in India, but also in other places where the challenges are different in many ways, but also have some common threads. And I've tried to hold those images in my head, hard as they are, to keep me motivated in my career and to help me feel that tug to action. So today I'm going to share with you three ideas. First, that solving the problems of teenage girls is the essential and often the missing piece of the global health agenda. Second, that when girls thrive, economies grow, and we have a chance at long-term reduction and even elimination of poverty. Third, that there's progress behind and a truly exciting agenda ahead. Gender-based discrimination does not start in adolescence, and we know that from the imbalance in sex ratios in China and India and elsewhere, as well as reports of female infanticide and poor nutrition and health of girl children. But adolescence, starting maybe around age 10, is the time when puberty brings around about physical changes. Gender roles get very sharply defined, and girls move from childhood to adult roles as wives, as mothers, as workers, as citizens. And as they do so, their choices too often are constrained. During this part of life, social and health behaviors are established that have a lifetime of consequences. And you simply cannot address much of the global health agenda without recognizing the importance of the teenage years. Some of the major risks that girls face during the teenage years has to do, not surprisingly, with sex. When girls in low-income countries experience sex, it is often within the context of sexual violence. A few years ago, the World Health Organization did a really seminal study, multi-country study, trying to get a sense of how large the problem is of sexual violence among young people. So they did surveys in Latin America, South and Southeast Asia, and Sub-Saharan Africa, finding that on average, somewhere around a quarter of girls between 15 and 19 years old had experienced sexual violence. And for many, this started a pattern that repeated in older ages. For many girls, their very first sexual experience was in the context of violence, often with much older men. The high rates of sexual violence and exploitation of girls and young women found everywhere has its most devastating consequences in countries where HIV is most prevalent. In South Africa, one of the countries where the epidemic has its firmest grip, a prevalence survey in 2008 found that 1/5 of all women aged 20 to 24 are HIV positive. That's 3 times the rate of men in the same age group. 1/5 of young women aged 20 to 24. And 1 out of 3 women are infected by age 25 to 29. Sexual violence is both a precursor and a consequence of early marriage. Fully 1/3 of the world's girls are married before they reach the age of 18, almost all to men much their senior. And while we tend to think of this as a phenomenon in India, Bangladesh, Nepal, Pakistan, it's really the countries of West Africa where this is much more the norm than the exception. In Niger, for example, 3 out of every 4 girls are married by the time they are age 18. And in the Central African Republic, about 2/3 of girls are married by that age. And where there is sexual violence and early marriage, there is risky pregnancy and unwanted pregnancy. There are 15 million pregnancies to girls 18 years and younger in developing countries every year. And those pregnancies are indeed risky. Women are twice as likely to die in pregnancy and childbirth when they're under 20 as if they deliver when they're older. And many of those pregnancies are unwanted. Each year, at least 2 million young women undergo unsafe abortion in developing countries, often with devastating consequences. In Nigeria, which we've heard a lot about recently with the abduction of the high school girls, the most populous country in Africa, complications of abortion account for almost 3/4 of all deaths in young women under age 19. And half of all maternal deaths in the largest country in Africa are attributable to unsafe abortion among adolescents. The risks extend to the babies. Elsewhere, as here, babies of teenage moms are more likely to die before their first birthday than are infants of older mothers, and children of young mothers are at higher risk of many bad outcomes, worse health, poor nutrition, worse education outcomes. So those are the relatively short-term risks for women, the longer-term risks for their children and their future families. But there are also long-term risks for girls themselves. Girls who engage in unsafe sex, who are exposed to violence, too often suffer from long-term effects of pelvic inflammatory disease, infertility, and cervical cancer. There are other long-term consequences of risks in the teenage years that go beyond those associated with sex. For example, smoking-related behaviors are often established in the teenage years, and increasingly, cigarette manufacturers are targeting young women in developing countries as the next market to pursue. So if we care about HIV and AIDS, about contraceptive use, about unsafe abortion, about maternal mortality, about infant mortality, child health, and even about chronic diseases later in life, the global health agenda, then what matters is paying attention to what goes on during the teenage years. Despite this, and despite tremendous international enthusiasm for child health and maternal health, little is being done to attend to the needs of adolescents. From the time a girl receives her last childhood immunization at age 5 until she shows up for maybe a prenatal visit, or more often for delivery or for dealing with the complications of a pregnancy gone wrong, she is not seen by the healthcare system. And while you might think that schools would provide opportunities for health education and even for preventive care, too often they create more problems than they solve. There was a study issued last year by the Center for Reproductive Rights that found that in Tanzania, for example, secondary school girls are subjected to forced pregnancy tests, often once a month. And if they're found to be pregnant, they are expelled. A tiny fraction of public health dollars, including support from donors like USAID and the World Bank, is dedicated to the health needs of adolescents, although much is devoted to the aftermath of problems that are not resolved during those years. And the neglect extends very much to data. We know so much less about the lives of adolescent girls and the health problems that they face than about people in childhood or in older ages. And just as one example, the Demographic and Health Survey, which is one of the main sources of information about health in the developing world, the sampling frame in most countries, and it's covered now more than 90 countries, the sampling frame in most countries is restricted to married women. So it misses a large share of adolescents. And precisely because dealing with adolescent health and protection touches upon deeply held social norms and taboos, it takes bravery by governments and by donors to really confront the problems and to look with open eyes at what's going on. And very few governments or donors are, in fact, brave enough to do this. So maybe part of the solution lies within the health sector, but much probably lies outside of the health sector and outside of the health sector budget. Maybe we need to show how connected the health of teenage girls is to powerful drivers of future prosperity and to the stability of nations. Increasingly, national leaders, presidents, and ministers of finance, as well as international powerhouses like the World Bank and the International Monetary Fund, are in fact recognizing how important the work and productivity of women is to long-term economic growth and the reduction of poverty. Last year, in a kind of breakthrough moment, the IMF released a report called Women, Work, and the Economy: Macroeconomic Gains from Gender Equity. And this is a title that I think years before would never have been seen under an IMF imprint. And it put on the record a sweeping set of findings about the importance of decent work for women as countries advance economically. The IMF stated, for example, that in industrialized countries, bringing more women into the workforce can mitigate the drag on the economy that's associated with an aging population. And for low-income countries, they talked about the virtuous cycle: more work opportunities for women leading to more control of mothers over income, more investment in education of children, and all the benefits that that can bring. I'm not sure I can convey to you how important it is for the IMF to connect the dots between the health and well-being of girls and women and the macroeconomic futures of countries around the world. It really elevates the conversation and hopefully the response. Some countries that have had impressive economic growth in the past decade or more, including India and China, are seeing that sustaining that growth really depends on bringing more women and more well-educated women into the workforce to deal with what's increasingly becoming a shortage of labor. And the story plays out in Africa as well in a slightly different way. Countries such as Senegal and Kenya and the Central African Republic, which you probably do not think of as kind of as economic powerhouses, are actually poised potentially on the brink of an economic boom. If they're able to bring down their fertility rate, they will have a relatively large share of the population in the working ages and few in the older ages and in the younger dependent ages. And when that happens, there's tremendous potential for rapid economic growth. It's called the demographic dividend or the demographic bonus. And many countries around the world have experienced that. The countries of Africa are on the verge. So you know from our own economy how important the age distribution is for economic prospects. And now in Africa, it's becoming very common for presidents and finance ministers to really recognize how their future economic prospects are driven by what happens to the birth rates in their countries. So to achieve lower fertility rates, women need to start childbearing later. They need to wait longer between births and have fewer children overall. And those changes, of course, depend on delaying marriage. They depend on access to contraceptives. They depend on an expanded set of life choices for women. And that means attending to the needs, the educational, the social, and the health needs of teenage girls as they start into their adult lives. So the demographic dividend that many governments in Africa are eagerly anticipating simply cannot happen if the needs of adolescent girls aren't put onto the agenda in a very prominent way, and if their rights are not fully respected and protected. But here we are in beautiful Palo Alto, far from the places I've been talking about, and maybe we care, maybe we act charitably, but what might we be able to commit to doing, and particularly this group could commit to doing, so that girls and young women elsewhere can enjoy the same health and well-being that we want for our own daughters and for our students, and that we wanted for ourselves. Let me just hint at an agenda for action and research in several domains, and I think that many will be touched on later in the conference. For those who work in public health and in clinical services, a lot of progress has already been made, but there are many, many unanswered questions about how best to serve this kind of newly emerging population. We're at a moment in the developing world where we have the largest ever cohort of young people, and they need services that their governments, the private sector, and those who want to assist from outside are not yet prepared to respond with. The knowledge that exists, for example, about family planning and other kinds of reproductive health services is really focused on older married women, much different moment in their lives, and the models of care are based on an understanding of what they need. We need to understand teens. What can we learn, for example, about the effective ways that mass media has been used to reach teenagers, both here and abroad? What forms of birth control are best for them? How can girls subject to sexual violence be protected both from unwanted pregnancy and from sexually transmitted diseases, including but not only HIV? We need creativity and research on methods of protection, and importantly, on delivery of services. For those who work on biomedical research, many scientific questions, you're in a much better position than I to identify them, need to be answered to develop better products to protect against pregnancy and sexually transmitted diseases. And I just want to call out the introduction of HPV vaccine, which is rapidly kind of gaining traction even in low-income countries, is a potential game changer for cervical cancer prevention. But the 3-dose regimen presents financial and operational challenges that are really significant. So I don't know if it's possible, but if I had a magic wand to wave, it might be for a 1-dose HPV vaccine. And for those who work in the social sciences, the agenda is broad and diverse, and I think exciting. It ranges from better understanding how social norms are developed and how they're changed, because some are changing quite rapidly. I talked about the problem of child marriage, but actually the incidence of child marriage in most parts of the world is declining very rapidly. So understanding why is that happening and how can it be accelerated. The social science agenda also includes evaluating a range of exciting, promising programs that have not yet been rigorously evaluated, and developing policy recommendations to really encourage gender-sensitive economic and social policy. And part of that is getting better information about the conditions of the lives of girls and women. For all of us, and I know all of you are national and global leaders, you're community leaders, we have an opportunity and a responsibility to make visible the challenges that girls face and to call out the failure of governments, others, and particularly our own in protecting and defending human rights. And we can call on governments, and again, particularly our own, to really pay attention to the needs of adolescent girls within the global health agenda. You know, for our development agencies, USAID, the Millennium Challenge Corporation, the World Bank, the one sector that that very consistently gets great support from the American public is global health. And most of the development assistance money in our bilateral programs like USAID goes into global health. So making sure that that money is focused in large part, on responding to the needs of adolescent girls, as it now is not, is part of the agenda ahead, and where we can raise our consistent and persistent and insistent voices for change. So I started with a really sad story. Let me end with a somewhat happier one. At the Hewlett Foundation, we have the really great privilege of being able to award grants to fantastic organizations around the world and doing great projects. And one of them I'm really excited about. I'm excited about lots of them, but I'll tell you about one I'm truly particularly excited about. In Zambia, we are supporting clinicians at Marie Stopes International, which is, as you may know, one of the largest and a really great provider of reproductive health services around the world, to work with IDEO.org, a design thinking firm just in our backyard here. And what the IDEO.org team, many of them very young, are doing is really diving into the conditions of teenage girls' lives in Lusaka, Zambia. They're doing rapid field work to understand how teenagers live, how they think, where they shop, how they get information, where they go to party, what they do, and who they trust. And with that understanding, they are working with Marie Stopes to reshape the kinds of services that that organization provides, so that they're able not just to reach the moms of these girls, but the girls themselves in a way that's responsive and that the girls can trust. And one thing that we see with this project is how much of a connection there is between the young staff of IDEO.org and the young women in Lusaka, Zambia. When they're shopping and talking and brainstorming together, they are also laughing together. And that sort of young energy really gives me a tremendous amount of hope that they will develop a whole new type of information and services that will truly serve the next generation. So I wish you all the best for a great conference, and really appreciate the chance to speak with you today. Thank you.